Ear skin tags are really pretty common. Parents can choose to leave these alone, or they can choose to have them removed. It's going to depend on how big it is, what it looks like, if it's bothersome to them. But ear skin tags are really pretty common. When we're looking at their umbilical cord, when I talked about labor and delivery, we talked about remembering how important it is to check that umbilical stump to make sure that we have 3 vessels and that we have there's 2 arteries, 1 vein, and this picture really shows them quite nicely. I have one over here to the right, one on the center, and one on the left. Polydactyly is just an extra digit. Treatment is really dependent upon the size and then involvement underneath the skin. So you can have it as severe as, an extra digit having bones, ligaments, tendons, those types of things, or it can be very small, minute, and minor, and it's something that maybe they're able to just clip off and not really do anything with. So when you're thinking about treatment options, really just dependent on how much involvement there is underneath the skin. Clubfoot. When we see clubfoot, the treatment for clubfoot continues to be surgery and then serial castings. So meaning that they apply and reapply, remove, apply, reapply, remove. Serial castings. Treatment usually starts about 2 weeks after delivery. So we make sure that the newborn is stable. Adapting to extrauterine life well. So really what we see is this casting done. There is also the Ponseti method, and that is given out in more detail in your book, but very, not, obviously going to cause some pain and discomfort to the newborn, but something we definitely want to get treated. Congenital hip dysplasia occurs when there's some type of anomaly or congenital defect in the hip area. When physicians are doing their newborn assessments, they check the Barlow and Ortonali, Ortolani, Ortonali. They check those maneuvers and feel for hip clunks or a dull feeling, I guess is another way to describe it. But what they're feeling for are clunks or clicks when they are moving the newborn's hips, and when they feel those, they can investigate further, do x-rays, things such as that. The simian crease is just one single crease that crosses the palm. Typically, if you take a moment and you look at your hand, you can see that you probably have 3 creases. So typically we have 3. If you have an infant that only has one simian crease, oftentimes that can be indicative of developmental problems. We look at their gluteal folds for symmetry. If you have asymmetric gluteal folds, sometimes that can also be associated with congenital hip disorders, dislocations, things such as that. So turning that baby on their tummy, looking at them, and looking at how you see the gluteal folds on their backside. Pilodontal dimpling is just a little dimple above the anus. Oftentimes, if you have a newborn that has pilodontal dimpling, they will develop into cysts later in life. Doesn't really require or cause any harm or need treatment in this age, but sometimes it will develop into cyst and create tunneling, and then they'll need to have that removed as they age. Newborn hearing screens are done after 24 hours, as well as on every newborn that is born in the state of Iowa. And the reason being with that is that if hearing loss is detected early, we have better outcomes. So it all goes back down to early intervention, early treatment, better outcomes. And they just put a little tip inside of the infant's ear, push start or run or scan on their machine. And when the infant is hearing in that, what they're hearing are several different beeps, and that will give an automatic report. If they pass, great, no problems. If they refer, oftentimes they'll come back to the OB department in a week, have it rechecked, and if they continue to be referred, then it will be referred on to an audiologist for treatment. Circumcisions, there is a YouTube video that we will watch, or you can watch it on your own. But with circumcisions, typically what you're going to be seeing utilized right now is the Gomco clamp. With the Gomco clamp, it's just a circumcision is the removal of that foreskin. It's done by a physician. Oftentimes we will give Tylenol post-procedure. We will use sucrose during the procedure with a pacifier. With the Gomco circumcisions, we do instruct patients that they need to use Vaseline on the end of the penis. And the idea behind that is so that the penis doesn't stick to the diaper when they do diaper changes. With the Plastibell, and there's no reason to use Vaseline. The end of the penis is not as raw as with the Gomco. And then with the Plastibell, it is just actually a plastic circle that sits around the end of the penis and then eventually falls off after probably a week, 10 days. Things when you are providing care to this newborn. Standard precautions goes without saying. Remember that you need to wear gloves until the infant has had the first bath. No matter what you're doing, you need to put gloves on. Always doing a head-to-toe assessment. Vital signs are going to be like your post-op patient. So every 5 minutes times 3, every 15 times 4, every 30 times 2, every hour times 2, and then every 4 hours until the first 24 hours of life. Remember, that goes without saying that if you have some type of abnormality, you are going to be reassessing further. Ensure medications and interventions are completed as ordered, and then update your care plans as necessary. When you are thinking about high-risk prenatal care, the really big focus, especially in our rural area, is how can we make that centered. When you're providing support, the family is really in a time of crisis because they're having this infant that maybe has something abnormal, or maybe has something going on, maybe they're not transitioning well, and we're not going to need to be considering sending them out for care. So when we're doing that, you just need to look at your family. How is your family acting and reacting? Offer that support. Always anticipate or think about your anticipatory guidance and what you can expect, or think about what you should be expecting, and then make sure referrals are made. Ensure that we're getting follow-ups once they're discharged. So really, it's a big emotional roller coaster, and we're going to be there to be advocates, to offer support, to offer education, and just really be their support person. So looking at Objective 8, we're kind of starting to talk about some of the complications that are associated with the newborn. And with those, respiratory distress is very common to see. Oftentimes you'll see respiratory distress, and if it occurs outside of that transitional period, then we're really going to need to be watching this infant closely. So clinical manifestation, nasal flaring, think back to advanced concepts. And with nasal flaring, that's the number one way to tell or to determine or think about respiratory distress. So grunting respirations, tachypnea, central cyanosis, retractions, all of those things that you think about with your adult patient are going to be happening in the baby. So oftentimes it's good to just leave the baby's t-shirt off, watch their chest, visualize what they're doing, watching that pulse oximeter, watching those blood glucoses, because we oftentimes see hypoglycemia as well. So really watch that newborn's blood glucoses and temperature. Etiology, there's several different reasons listed out up here. So lots of different things that you can be thinking about associated with respiratory distress. Choanal atresia is a very common, or most common, not very common. It's a common anomaly of the nose. And when you are thinking about choanal atresia, it's created by the posterior nares being blocked. And it can be blocked with soft tissue or a bony structure. and it can be either be unilateral or bilateral. So when you're looking at diagnosis, there's an inability to pass a suction catheter through the nose. So really what I want you to take away from this is respiratory distress is going to be highly common because newborns are obligate nose breathers, remember, up to 3 weeks of life. So we want to keep that infant in a prone position. So think about what prone means, and if you don't know what prone means, you need to look it up. And then secure an oral airway into that posterior pharynx so that we are maintaining an airway and oxygenation for our baby. Congenital diaphragmatic hernia is just a defect in the diaphragm, and the abdominal organs are then displaced into the thoracic cavity. We see different sizes of defects, and so when you're thinking about treatment options, obviously it's something that is going to need immediate treatment because it can cause GI, GU, central nervous system. It can cause lots and lots of different complications and effects. So, but the size is really going to determine prognosis. So the larger the hernia, the poorer the prognosis, or poorer the outcomes are going to be for that newborn. So medical care is obviously surgery at a tertiary care center. So sometimes, most oftentimes this is going to be caught on an ultrasound, and so that mom will probably deliver in a larger facility anyway. If not, then we're going to transport that baby as soon as it is stable. When you're thinking about nursing care prior to procedure, administration of nitrous oxide, and if you recall, nitrous oxide is the quote-unquote laughing gas that's used at the dentist. But the reason we use nitrous oxide in newborns is to treat persistent pulmonary hypertension. So you will be seeing that utilized. Aspirating the gastric contents to keep that area decompressed so that as the stomach would fill up with gastric contents, it's not going to put more pressure or undue stress on that hernia. And then oxygen therapy, or obviously mechanical ventilation if necessary, to treat any of the acidosis. Persistent pulmonary hypertension is related to a left to right shunting or persistent fetal circulation in an otherwise structurally normal heart of the newborn. What you're going to be seeing with that is persistent tachycardia as well as cyanosis in that term or near-term infant. Again, we're going to administer nitrous oxide because, as I said in the previous slide, we want to decrease pulmonary hypertension, and that will work as a vasodilator. We will use mechanical ventilations to decrease carbon dioxide and increase oxygen saturations. So providing support to the family members will be very important, and we will have these little stinkers be in intensive care units. So what you will do, or what will you do, if you have an infant exhibiting signs of respiratory distress or with meconium aspiration syndrome? Typically, respiratory distress obviously is going to be related to the lungs because we're talking about respirations. And oftentimes with respiratory distress syndrome, we see that because there's a lack of surfactant, and we have discussed what surfactant is. And so we see weak respiratory muscles and an overly compliant chest wall, or it could be due to some type of debris in the airway, which would be the meconium aspiration end of things. So what you're going to be looking for is that these symptoms will typically appear either almost at time of delivery or within 6 hours after birth. And so when you think about poor sounding lungs, crackles, grunting, nasal flaring, retractions, all of those types of things you'll be seeing. Watching that pulse oximeter. If it leads to central cyanosis, then we know that we're in the later stages of the game and we're going to need some more support. So treatment is obviously supportive until we can get it corrected, and ensuring that we have good, adequate ventilation and oxygenation. Surfactant will be administered to those newborns that are preemies, and then the nitrous oxide, as well as fluids, and then monitoring arterial blood gases. So we can get any type of acidosis or treated so that we don't have detrimental side effects to our newborn.